Hello, and welcome to a new episode of the Dysphagia Matters podcast. I'm Julia, and with me is Jule.
Hello. We are slowly approaching the holiday season, and with it usually come glowing decorations, talking toys, and endless gadgets that make the season bright. But tucked inside many of these devices is a hidden hazard, the button battery. Small, shiny, and easily swallowed, it can turn celebration into emergency in a matter of hours.
To help us understand why time is critical and what can be done, Professor Kris Jatana joins us to share his expertise on button battery ingestion, its effects on swallowing, and how awareness can save lives. Kris is an expert in pediatric otolaryngology, and since 2012, he has served a leadership role on the National Button Battery Task Force. His innovative ideas have resulted in several clinical practice guidelines and industry changes.
We hope you find this episode interesting, and maybe you also want to spread awareness about the risks of button battery ingestion. Enjoy listening. Hello, Kris, and welcome to the Dysphagia Matters podcast.
Thank you. It's great to be here.
We did a quick online search using the terms swallow and button batteries, and multiple news headlines came up, such as this one from the New York Times from 2022. More children are swallowing batteries and landing in the ER. Or another one, urgent health warning to parents after cases of children swallowing button batteries from ABC News Australia just 4 months ago. So this seems to be a very important topic, but at the same time, one that does not receive enough attention. To start this conversation, Kris, could you briefly explain what button batteries are and where they can be found?
Sure, absolutely. So there's numerous devices, electronic devices in the household setting that contain button or coin cell batteries. These can be remote controls, sometimes toys, games, tea candles, garage remote control openers, key fobs, numerous types of electronic holiday decorations, and hearing aids, watches. Things like that do contain button or coin cell batteries. So they are frequently found in the household setting. They look like disc-shaped or sort of button-shaped batteries. So this is kind of an example. But the challenge with these is that if they do become ingested, they can get lodged within the esophagus and cause serious injury. They also can be placed in the nasal cavity or ear canal and also cause serious injury.
And what exactly happens when these button batteries are swallowed?
So the challenge is once it becomes stuck somewhere in the body, such as the esophagus, for example, the current that's generated by the battery basically is conducted through the esophageal tissue. So in the presence of saliva, human tissue, a current, essentially the water component breaks down into a highly alkaline substrate we call hydroxide ions, and also hydrogen gas gets released. As a result of this, very quickly, within minutes, the pH of the tissue rises significantly to a very toxic level that essentially dissolves tissue. The term that we use medically is called liquefactive necrosis, and it's exactly what it sounds like. It basically dissolves and liquefies tissue rapidly. And so when we think about other types of caustic, ingestions over the years, such as lye and other things that are less frequent now than they used to be, this is basically a similar type of highly alkaline caustic injury, but it's powered by the voltage of the battery.
Okay, so it can be very dangerous. In a review on the current management of button battery injuries that you and your colleagues published, you write, unfortunately, many button battery ingestions are unwitnessed in children, and information regarding battery type, charge state, number of batteries ingested, and time of ingestion remains unknown. How can we then identify a child that has swallowed a button battery, or are there any typical symptoms that we can observe?
So it's a great question. In some situations, a parent may witness from across the room or suspect their child swallowed a battery, because there's a missing battery from an electronic compartment, and the child has some symptoms of coughing or choking, noisy breathing, vomiting, more irritable. They can tell something's wrong with their child in sort of an acute setting. But that's not always the case, and it really depends on the diameter of the battery, how large it is essentially, the size of the child, the size of their esophagus, and where it gets lodged, if it gets lodged. So those all go into causing sort of the acute symptoms, but within 2 hours, serious injury can occur, within the esophagus, and so there's not a long time frame to try to intervene and get the battery out when it does get ingested and stuck in the esophagus. And some children in various situations do have absence of a lot of symptoms. And so if a parent didn't witness or suspect the battery ingestion, sometimes hours can go by while that injury is occurring, and the symptoms can present much later that day, for example, than in the acute first couple hours. So I think you just have to have a high index of suspicion, be aware of this hazard, be aware of any kind of electronic devices that are in your household that contain them, keep a ongoing sort of inventory of these things, making sure that they're in a secure compartment, for example, and storing any kind of new button batteries in a locked or secured cabinet or container out of reach, out of sight of children.
And I guess not only the new ones, but also the ones that have been used.
Yes, that's a great point as well. We do recommend when a battery is removed from a device that no longer powers it, it still has enough residual charge actually to cause injury if it gets lodged in the esophagus. And so our research has shown that a simple strategy of just wrapping tape around the battery bidirectionally, so any household tape, duct tape, scotch type tape, packaging tape, just basically covering the battery in both directions with a complete layer of tape. At least it can help protect the tissue from coming in contact with the battery. Should it be ingested, it's probably less likely to get ingested as well when it's covered in tape. If it were to get ingested, the risk is definitely much less because of that. I think the other thing is just keeping those in a locked container, compartment, or cabinet, essentially until you can take them to a recycling facility or a hazardous waste disposal facility, for proper disposal. There's different guidelines depending on the state, country, city that you live in, and we recommend checking with your local rules and regulations regarding that. But definitely want to make sure that not only the new batteries are stored in a locked, secured cabinet or container out of reach, out of sight of children, but also when you take them out of devices to keep them in a secure location. We have had children that have unfortunately taken batteries out of the trash can just because they happened to find a shiny object in the trash can and then accidentally ingested those batteries and caused serious injury, and those no longer powered devices. So
Yeah, wow. And you said it makes a difference if the child is smaller or larger, younger or older. In which direction? So is it more severe or more dangerous for younger or older children?
the risk of severe injury or death is much greater in younger children. I think that the diameter of the battery is really important. The 20 millimeter diameter 3-volt lithium batteries are more likely to get stuck, even though we have seen the smaller diameter, even non-lithium type batteries get stuck in the esophagus of children under the age of 2. The injury can occur with either type of battery, but it's just a little bit slower with the non-lithium batteries that have half the voltage essentially. But the size of the battery really determines where it gets stuck based on the size of the esophagus. And younger children are just more likely to have a battery get stuck than an adult, for example. We actually do see a lot of ingestions in the elderly population for adults, just with dexterity and sort of visual compromise and hearing aid batteries and other things that they mistake for pills. And so we do have some older populations that do ingest button batteries as well. But fortunately, because their esophagus is bigger, and a lot of those types of batteries that power hearing aids are actually the zinc air type, which are a little bit safer profile than the other lithium type batteries. They actually require oxygen to get into the battery to conduct current. And so once it becomes wet in sort of a aqueous environment, such as the esophagus, it's just less likely to cause injury. But we do see those types of batteries inserted in the nasal cavity or ear canal, which is dry, and then can cause septal perforations and ear canal injuries, things like that, which have occurred. So the risk isn't negligible with even those types of batteries, but we do see a lot of them ingested. It's just in the elderly population, fortunately, it's a smaller diameter battery, an adult patient with a wider esophagus, and just less likely to actually get stuck in the esophagus. But that still doesn't mean they're not a hazard for grandchildren and other family members that may come to visit that grandparent that leaves these around. And so it's just really important to be vigilant and keep them in a secure location.
Yeah, and when you say it's not that likely to get stuck in the esophagus, it probably just goes all the way through to the stomach, but it then can cause harm there.
Once it gets into the stomach, because the stomach is weak, is an acidic environment and the battery is not lodged in a specific location, it's just less likely to cause any kind of severe gastric injury. Our guidelines for removal once it's in the stomach or beyond are really based on the presence of symptoms. It's just very rare that you would have a severe gastric injury or proximal intestinal injury from a battery that's passing through the lower gastrointestinal tract. Just because it's moving, it gets food and stomach acid around it, and it's not lodged in a specific location like the esophagus or inside the nasal cavity or ear canal, for example. And so those are obviously much more hazardous locations. When I say it's less likely to get stuck in the esophagus, it's really just for those adult patients. For the smaller diameter batteries, they're just much less likely to get stuck unless there's some type of underlying esophageal pathology, in those patients. But children, for example, even a normal size esophagus in a 1 to 2 year old child, unfortunately, can lodge a even smaller diameter non-lithium type battery.
And what does the diagnostic process look like? How do you identify where exactly the battery got stuck?
Sure. So if parent suspects or witnesses their child may have ingested a button battery, we recommend that they start honey, which is basically a mitigation strategy for reducing the speed of injury. So in the household setting, if honey is immediately available, to take 2 teaspoons of honey every 10 minutes, basically until that child can get to the emergency department. If honey's not immediately available, we don't recommend people stop at the store to get it on the way, obviously, but you just want, if it's available, it can slow the rate of injury by sort of being a protective coating, and it's also weakly acidic and a viscous barrier, within the esophagus. And so our studies have shown that we can slow down that rate of injury with a simple solution like that, sort of a first aid solution, until a child can get to the hospital. And once a child gets to the hospital, just the history alone of just suspecting or witnessing a button battery ingestion, getting a X-ray is the next step to evaluate if and where it's stuck in the esophagus, and typically evaluating for not only where it's stuck, but making sure that there's no other foreign bodies. Sometimes children will ingest multiple foreign bodies, unfortunately. Those are part of the evaluation as well, especially if they're going to be going to the operating room. It's rare that these get aspirated. They can get aspirated in some children. Smaller diameter batteries can make their way into the trachea or lower airways. And obviously that's a more life-threatening situation acutely with just airway obstruction. However, when they're in the esophagus for a prolonged period of time, they can actually essentially burn a hole into the trachea and also cause vocal cord paralysis and other things that are also life-threatening. The most devastating sort of complication that we see from a button battery injury in the esophagus is erosion into major arterial blood supply, such as the aorta or branches off the aorta. That is a massive hemorrhage that's acutely life-threatening in more than 90% of patients who do experience that. And so prompt treatment for removal once a battery is identified on X-ray and known to be lodged in the esophagus, emergent surgical removal is the mainstay of treatment.
So it's very important to be very fast as parents or as anyone who witnesses that the child ingested a battery. You mentioned the honey. Are there any other additional management strategies that someone could apply?
In the home setting for parents, caregivers, the honey is really the best option. In the hospital setting, we did show that sucralfate or Carafate, which is actually a medication that's approved for use in duodenal gastric ulcers, that solution also is equally protective as honey, and it's sort of a medicinal option that's available, in a hospital type setting. And so either of them can be used interchangeably once a child gets to the hospital until they can get to the operating room. But those are the main two mitigation strategies for prior to removal of the battery. We did do research to show that after the battery is removed, there's obviously a highly alkaline substrate that's in that esophagus, and unfortunately, over time, and this is why we see delayed complications after batteries have been removed, is that tissue can break down through that liquefactive necrosis process that we talked about earlier, and that can happen over days to weeks. And so ways that we can try to neutralize that high pH in the esophagus after removal is what we recommend today. And these recommendations are part of our National Capital Poison Center management guidelines, essentially to irrigate that injured tissue in the esophagus with a 0.25% sterile acetic acid. And to do about 150 milliliters of irrigation can help neutralize that to a more physiologic pH. So we've been doing this for years, and it certainly has improved visual appearance. A lot of the highly alkaline substrate gets washed out. So our thought is that it may help slow that progression of injury over time as things are healing. And basically, it's a 20th the strength of the home white vinegar that you use in your kitchen, but it's a sterile solution. So it's very safe to use for this purpose. And endoscopists and surgeons who remove these do irrigate the esophagus to try to get rid of that highly alkaline pH and clean out the debris from the injury. The only situations where the endoscopist or surgeon may think that it's not best to do that is if there's an obvious severe injury where you'd be irrigating into the mediastinum or that type of thing. So,
okay, just one step back. One question came up regarding the diagnostic process. Are there any differential diagnoses that should be considered?
Yes, so great question. So I think obviously when we have a known or suspected ingestion, it's much easier to try to explore this diagnosis. But when that unwitnessed, unsuspected situation is there, a lot of these children, unfortunately, can present with these vague symptoms that are very common with upper respiratory and GI viruses, for example. We see a lot of children with croup-like symptoms, for example, symptoms of a common cold in a lot of cases. So sore throat, fever, irritability, vomiting, and not interested in taking oral intake very, very well. And those are unfortunately challenging situations for practitioners in different medical environments to be able to make that early diagnosis, because we can't get an X-ray on every child who has these vague symptoms. There is a risk of radiation exposure over time and malignancy risk. And so, getting an X-ray on every child who has one of these very common symptoms is just not recommended. And so it's challenging in this situation because, the time is of the essence. But until we have better screening modalities available, for button batteries, the X-ray is really our mainstay of diagnosis assessing for this condition.
Maybe now going back at the point where you have identified that a button battery was ingested, how do you actually remove it? Are there specific instruments, techniques?
Yes. So patients put under a general anesthetic as part of the procedure. We do recommend considering an airway evaluation at the same time as removal, just because if the negative pole is facing anteriorly, that's where the injury happens the most quickly. It's basically facing the parting wall between the trachea and the esophagus. And so in that situation, those patients are at risk for developing a tracheoesophageal fistula. Knowing that ahead of time can be helpful if you're taking a battery out, because once you take it out, then you have this sort of blowhole between the two structures, and sometimes that can lead to challenges during the anesthesia. So frequently we'll do a quick airway evaluation as part of just the intubation, just to make sure that we don't have those types of scenarios. It takes less than a minute to do, but at least you have that reassurance of what you're up against. And then intubating to secure the airway. The esophagus can be evaluated two ways, one with a rigid esophagoscopy and also with a flexible esophagoscopy. It really comes down to endoscopists or surgeons' preference on what they're most comfortable with. Both techniques can accomplish removal successfully. The rigid technique, essentially putting a esophagoscope into the proximal esophagus and passing it distally until the battery is seen, and then using an optical forceps with a high definition camera, really improves visualization of the actual grasping of the battery and removal. The graspers with the rigid esophagoscopy are much more, much stronger. And so if you have a difficult to remove battery, I do think this technique works better than the graspers that are available for the flexible bronchoscopy. They just aren't quite as strong to solidly grasp difficult battery. Obviously, whatever the endoscopist or surgeon's most comfortable with, and just having a backup plan if it's difficult to remove.
Yeah, okay. So you're very active in terms of advocacy and prevention strategies, and you've already mentioned that the best way, of course, is to just lock the button battery safely, no matter if they're new or old, or also the gadgets that are being used with those batteries. But are there any prevention strategies that could be applied maybe in more general, or maybe not by the individual, but just the society or the companies producing the button batteries?
Sure, great question. So this has been one of my advocacy projects, I guess, since 2010 when I first took care of a child who was 2 that ended up requiring a tracheostomy to be placed just because of bilateral vocal cord paralysis from a 20 millimeter 3-volt lithium battery. They got stuck in the proximal esophagus, and you can imagine how that's a life-changing event for an otherwise healthy child. And working with industry over the last 15 years in a collaborative way, sharing data, sharing these stories, we've been able to make a lot of progress together. Packaging for the batteries is much safer today than it was 10, 15 years ago. You'll notice that nearly all manufacturers around the world use child-safe packaging, so it does require a consumer to actually get a pair of scissors and cut the battery out of the packaging. We know from data in the past through the National Capital Poison Center that about 10% of ingestions came from packaging in the past, where you can kind of pop out the battery like a piece of bubble gum. That type of thing did occur. It's an easy way for us to try to make the packaging more safer, in collaboration with the battery industry. I think warning labels and just information for consumers is really important as well. And those have been improved over the years to direct the consumer to the fact that this can be hazardous if ingested, and serious injury can occur within 2 hours, and just making it very clear to the consumer of the hazard that they're purchasing and bringing into their home. Beyond just the batteries themselves, obviously these batteries exist to power a product, and thinking through the products that you purchase, making sure that they're compliant with industry standards for security of the compartment, things like that are really important. And so the fact that industry has evolved their compartment safety to be more secure, child-resistant compartments for the batteries is a standard that should be met. And trying to keep those batteries out of reach, out of sight of children is really critical. And I think that while the standards do exist, it doesn't mean the risk is zero. And I think just thinking through, that sort of regular inventory of batteries, ensuring that compartments stay secure over time, because you can imagine a young child throwing something on the floor numerous times over time, can potentially damage or weaken that secure compartment. And so just thinking of strategies to ensure that compartment stays safe over time is really important as well.
And as far as I remember from your great talk at DRS, you've also introduced us to some strategies how the identification of swallowed batteries can be easier and faster. Can you maybe comment on that?
Sure. So I think just a couple newer technologies that have been put out on the consumer marketplace. There are some batteries I'm aware of from two manufacturers where there's a bitter coating on a portion of the battery that may be a potential deterrent for ingestion if it's facing the taste buds in the right orientation and way to potentially provoke that child to spit out the battery. I think, it's better than nothing. It still can be ingested. We've seen children ingest bitter batteries and they get stuck in the esophagus and they still cause the same injury. It's just a potential deterrent. The challenge we've had with bitterants and other types of chemical ingestions is that they have not always prevented those ingestions, unfortunately. The Energizer just came out this past year with a bitterant plus a blue dye. And so there are some 20 millimeter 3-volt lithium batteries on the market now that do have the bitterant and blue dye to potentially alert a parent that their child may have had a battery in their mouth and potentially swallowed it. If their tongue or lips are blue, it also can get on the fingertips of a child that may be related to a potential ingestion. Again, there's a lot of batteries out there that don't have that, and so we can't rely on that alone, but I think it should be something that parents, caregivers, and as well as medical professionals who may see these patients in the ED, needs to be aware of and ring a bell if they do see that in an unusual sort of picture. That is a possibility for some types of batteries. And I think just what we're looking for in the future is just a safe button battery, and currently that doesn't exist, on the consumer market. We have several technologies in development by industry for a safe battery technology. And, our American Academy of Otolaryngology Head and Neck Surgery has published a position statement stating, what that safe technology should look like. And it really should be a battery that essentially doesn't cause severe injury when it's lodged in the esophagus of a child. And I think that's what we ultimately need to protect children from these hazards. All these other things are things we've accomplished because they're common sense solutions to just trying to prevent these ingestions in the first place. But I think if you look at sort of hazard reduction and the hazard of the battery itself and ways that we can make that battery safer in the long run, that's going to be the most critical intervention. I think beyond just these new technologies for batteries, I think just ways that we can have a better way to have early detection of battery ingestions. We've been working on a new technology between Ohio State and Nationwide Children's here in Columbus to have a non-invasive radiation-free scanning technology, essentially to be able to detect batteries and coins in an expedited way for relatively low-cost devices that could be used potentially in the urgent care, ED, and pediatricians' offices when children do have non-specific symptoms. And that early identification and early diagnosis is really critical to best outcomes, and ways that patient's care can be expedited to get the battery out as quickly as possible is really important. So, look forward to the future where, we no longer see these injuries in children, but we have a ways to go, and optimistic that we'll get there.
That sounds great. And also the blue dye on the batteries, I feel like it's such an easy idea. It's so obvious. So it's great that solutions like these are coming into the market. So we are a dysphagia podcast. Of course, we have a special interest in dysphagia. So can you tell us something about whether these structural changes that occur due to the injury when a child has ingested a battery or battery in general, can these injuries lead to dysphagia?
Yes, absolutely. And I think that's one of the long-term challenges with these severe injuries to the esophagus. It obviously very quickly can cause penetration into the muscular layers of the esophagus, because the esophagus is not a very thick structure. And so it doesn't take long to cause sort of deeper permanent damage to the esophagus. And you can imagine sort of muscular layers getting injured, not being as peristaltic with swallowing for segments that are injured. One of the challenges, anytime you have a circumferential type injury to the esophagus over several weeks to months, you can get a stricture or narrowing that can be pretty small. I've seen some children stricture down to literally a millimeter of esophageal lumen. And so you can imagine you can't even get liquids through that. So, the choking, the difficulty swallowing when you have a stricture can be pretty severe. And, ways that we can try to dilate or stretch out those strictures in patients is sort of our first goal in treatment. And there are some patients that fail those endoscopic type dilations and ultimately need a resection, reanastomosis type procedure of the esophagus to try to improve it. I think beyond just sort of the esophageal stricture stenosis type issue, because the recurrent laryngeal nerves are very close to that tracheoesophageal groove on both sides, it doesn't take long for laryngeal nerve injury to occur with a proximal esophageal button battery that's lodged. And so with those types of nerve injuries in vocal cord paralysis, that can also lead to choking and difficulty with swallowing because of the vocal cord paralysis as well.
Mm-hmm. Okay, so we as clinicians also have to consider that even though the battery might have gotten stuck in the esophagus, so it mainly primarily esophageal dysphagia, it can also have influences on the other phases of swallowing. So it can also have influence on the physiology in the oropharynx, for example, or airway closure.
Yeah, so I think when you're trying, essentially with a stricture, you're swallowing against an obstruction, and so it kind of throws everything else out of sync. The fact that if you have a cord paralysis and liquids go down into your airway and you start coughing while you're trying to swallow, that throws your mechanism out of sync as well. We also have had children develop eosinophilic esophagitis actually after a battery ingestion and injury to the esophagus as well. The mechanism is still unknown, but we have had children develop that condition as well. I think the challenge is the long term, as you grow and your esophagus grows, when you have a stricture or just a stenosis, are you able to compensate with the growth and be able to keep that lumen open enough to swallow solids? Liquids are obviously a little easier with even a stricture or stenosis, but solids are the more difficult situation for patients that have these severe injuries to be able to have a lumen in the esophagus that's large enough to swallow safely. You can imagine how these injuries can be devastating from a swallowing perspective long term. A lot of patients do require a gastrostomy tube be placed for supplemental nutrition. We have had a lot of patients develop tracheoesophageal fistulas and vocal cord paralysis resulting in a tracheostomy. So, these types of long-term medical devices that are needed for a subset of these injuries, are really life-changing.
Yeah, absolutely. Thanks so much for giving this overview and insight into such an important, but a topic that's not paid enough attention to. Is there any final words that you want to share with our listeners who are primarily clinicians, students, but all interested in the field of dysphagia?
Sure. I think particular to your audience of these podcasts, I think that every clinician in every setting really has the opportunity to educate their patients on hazards like this. And I think just ways that you can pass on simple preventative information is really critical to preventing these injuries. And I think that everybody should feel empowered to try to do those educational efforts for these types of hazards that are commonly found in the household. And so I think that's a big opportunity that I think all clinicians who interact and interface with patients of all ages, frankly, can make a difference in the lives of not only those patients, but also their families and preventing these injuries. And I think that as we see technology evolve, our hope is that we'll continue to see a safe battery come to the market. But the data that we collect from these types of injuries is also really important. And I think just ways that we can continue to collect the best data possible on the outcomes of these types of injuries is really important to help drive the need for that safe battery from an industry perspective. And we actually started a reporting app. It's called the Global Injury Research Collaborative. It's an app that's available for iPhone users on the iOS platform and App Store. But it's essentially a way that any clinician can report injuries from choking or ingestion hazards beyond just batteries, but trying to collect data that we can use for industry to have safer product design, safer industry standards for choking and ingestion hazards. And I think that clinicians have that opportunity to advocate in a simple way by spending a couple minutes just reporting in an anonymous, de-identified way any cases that do cross their path, and ways that we can continue to work together in a collaborative way with industry with this data and information to make change.
Yeah, thank you. We will put the link in the show notes so listeners can find it. Thank you so much, Kris, for taking the time and for sharing your very valuable expertise with us and our listeners today. Thank you.
Thank you for having me.
Thanks so much for listening. If you enjoyed this episode, leave a review wherever you listen to podcasts. You can connect with us on Instagram, LinkedIn, and Blue Sky, or visit our website, dysphagiamatters.org. We'd love to hear from you. Until next time, take care.